And Dr. Thomas is the chief of the Division of Reproductive Endocrinology and Infertility at the University of Cincinnati College of Medicine. And he also is the principal investigator of Contraceptive Clinical Network on the National Institutes of Health. So I think that he's really an expert in his field. And he's going to talk to us about non-contraceptive benefits of birth control agents. And welcome.
Thank you. As stated, I have been in the development of contraception for many years. We'll talk a little bit about that at the end. But a lot of the products and devices and pills that we talk about, I was lucky to have been instrumental in developing. Despite all that, I don't have any particular disclosures for anything that's current. Oral contraceptives, of course, were developed in the 50s and then the 60s, and they're the most common method of reversible contraception in the United States. Most common method. I know that later on we're going to have a talk on LARCs and then another talk on abnormal uterine bleeding. So I'm not going to speak on those topics very thoroughly, but just to sort of use them in the context of the non-contraceptive benefits. And that's one of the issues. You know, as a reproductive endocrinologist, I always tell people I spend half of my day trying to help people get pregnant and the other half of my day trying to prevent people from getting pregnant. It's all hormones, and I can. My research, we talked a little bit today about stress and reproductive function. My research as a fellow was on how stress affects reproductive function by activating the hypothalamic pituitary adrenal axis with corticotropin releasing hormone, then looking at the effect of LH pulses by doing that. So I am well versed. That definitely piqued my interest when we talked about the hormonal aspects of stress. And birth control pills, though they don't do that and they don't tamponade at those types of issues in any way, shape, or form, they are very highly used. There are very rare side effects to birth control pills, even though patients sometimes are told otherwise. There are very few persistent or intolerable side effects, and there are actually very few absolute contraindications and many non-contraceptive benefits. I guess the first question I'll ask, because I have great interest in the history of contraception. There's a great article written by Malcolm Gladwell a number of years ago in the New Yorker about the history of the birth control pills, and John Rock, who was instrumental in developing the birth control pills. But my question to all of you, everyone talks about first generation, second generation, third generation, and fourth generation birth control pills. And depending on what you read, sometimes people will look at it from the perspective of the estrogen. And keep in mind that a combination pill contains both the estrogen and the progestin, but it's really the progestin that causes the contraceptive effect. But does anyone remember the difference between the first, second, third, and fourth generation? What makes a first, second, or third or fourth generation progestin? Anyone? Well, to be honest with you, it's sort of complicated because, as I said, depending on what you read, the first generation progestins developed from the original development of the birth control pill. The birth control pill was developed and introduced, as I'm sure some of you in this room remember, back in the early 60s. And it was generally a derivative of what's now norethindrone. It was norethindrone in a pill called Enavit. And you can see 150 micrograms of mestranol, which is equivalent to about maybe 135 or 130 micrograms of ethanoestradiol, mestranol, which is still in some of the birth control pills we market, like Orthonovum 150 has mestranol in it. And because it has a methyl group on the third position of the steroid structure, once that methyl group is cleaved, it's turned into ethanoestradiol. And so there's about a 33% equivalence when you reduce to take off the methyl group. So the first generation includes the norethindrone and the norethindrone acetate type drugs. The second generation are the gonades, which are the levonorgestrel and norgestrel progestins, which were introduced a little bit later, particularly in the higher dose pills. And then the third generation would be the norgestimate and desogestrel, which were introduced in the early 1990s. Then now the new fourth generation pills are the drospirenone pills. I recently was elected to the American Board of OBGYN in the REI division, so I'm always looking to ask these types of questions to our fellows on our exams. So that's one of the reasons I always like to bring these types of things up, because I think hopefully you'll see more and more of those types of things for the OBGYNs who take their MOCs and do their exams. But the birth control pills have changed, and the dose of the birth control pills have lowered, because we started out with, as we see here, 150 micrograms, and now we have pills like the low-estrin, which only have 10 micrograms of ethanoestradiol. So it's not really the estrogen, it's really the progestin that confers this effect. But the problem with, as you reduce the dose of the estrogen, you actually increase the amount of irregular bleeding, because the only reason you have the estrogen there is to stop the irregular bleeding or the side effects associated with bleeding. The other non-contraceptive benefits for OCs include increased menstrual cycle regularity. So by having the pills, you regulate the cycles, especially the combination pills. You lower the incidence of iron deficiency anemia because you decrease the amount of bleeding. Decrease dysmenorrhea, which we'll talk about in a little bit more detail. Decrease the incidence of functional cysts because you are actually decreasing follicular development. And you also decrease the incidence of ectopic pregnancies because you reduce the chances that patients can get pregnant. Other labeling for non-contraceptive benefits include the long-term use. There's a benefit for fibroadenoma and fibrocystic breast changes or breast disease, acute pelvic inflammatory disease, because by thickening the cervical mucus, you reduce the chances that infected sperm is going to get inside the uterus and therefore affect the tube in any adverse way. Also, you reduce the risk of endometrial cancer and ovarian cancer, which we'll talk about in more detail. As far as ovarian cancer is concerned, this is one of the things that I think that the birth control pills, both with the protection of endometrial cancer and ovarian cancer, by reducing the ability of the ovary to ovulate or reduce the rupture of the capsule of the ovary on a monthly basis, you actually reduce the incidence of epithelial cancers. 3 to 4 months of OC use reduces this risk of ovarian cancer by 40%. 5 to 9 years of use of birth control pills reduces the risk of ovarian cancer by 60%, and 10 years of use reduces it by 80%. And the protection begins just after using 1 year of birth control pills. Even though most people stop birth control pills after a short period of time, usually 2 to 3 years, the use of the birth control pill for a much longer period of time actually reduces this risk of ovarian cancer, and this risk is thought to be protective for even up to 15 years after discontinuation. Even OC use has been noted to reduce the risk of ovarian cancer, even in women who have BRCA1 and or BRCA2 gene mutations, and the greater risk reduction is associated with the duration of the pill. Keep in mind, though, that a lot of this risk reduction is noted in the higher dose pill. Whether or not this also is associated with the current low dose pills is yet to be seen. But it's thought that even though the amount of estrogen that's been reduced in the pill may still, you still may notice the fact that there may be some slight decrease in the risk of ovarian cancer, in these patients. The biggest problem with the reduction in the estrogen and the progestin in the pill is that you do see patients who ovulate, and sometimes you take these patients, and if you do an ultrasound on them, and we do a lot of ultrasounds in a lot of our studies because we have to show some degree of efficacy. And most of the efficacy, even in the low-dose pills, is thought to be due to the thickening of the cervical mucus. So the question is, do you continue to get this reduction in risk in the 20 microgram and below pills? As far as endometrial cancer is one of the most common cancers that is out there as far as gynecologic malignancies is concerned. just by using an oral contraceptive, the risk of endometrial cancer is reduced by 50%, and this protection lasts for even up to a year, begins at even 1 year of use and can last up to 15 years. And by using a progestin, that would decrease the risk of endometrial hyperplasia and therefore any eventual cancer. This helps to decrease that risk. So the use of an exogenous progestin, whether it's a progestin-only pill or even a combination pill, helps to reduce the risk of endometrial cancer. Other non-contraceptive benefits of the birth control pills including the progestin-only pill as well as the combination pill, includes improvement of benign gynecologic conditions. For example, you reduce the incidence of problems related to uterine fibroids. There's even some studies, and I'll show in a second, that even show that the incidence of developing fibroids is reduced if patients are given them at an early age. Improvement in bone mineral density is noted because of the estrogen in the combination pill is thought to decrease the risk of bone loss, and we'll talk about the use in the perimenopausal women. Favorable effects on lipid profile have been noted, reduced acne, improvement of perimenopausal symptoms, and improvement of menstrual cycle symptoms. As far as fibroids are concerned, it's been noted that not only do you reduce the risk of the bleeding and dysmenorrhea associated with fibroids, but there's also some data from 1999 that shows that patients who have been on birth control pills actually have a reduce in the incidence of fibroids. Even though we know that all women, the incidence of fibroids are known to be in women to 25% of the time in women, and maybe up to 50 to 80% of African American women, but only 50% of those women having any types of symptoms. But ever or never users, the odds ratio shows that there's no difference between those patients versus current or never users. It's thought that patients who are current users of birth control pills versus never users of birth control pills have a reduction in the incidence of fibroids. Former or never users, it's noted that there's no real difference. But the risk of uterine fibroids decreased with time in any patient who's ever used the pill. If they've used it for up to greater than 7 years, there was definitely a thought that the incidence of having fibroids and the symptoms of fibroids were reduced. As far as osteoporosis is concerned, osteoporosis affects up to 8 million women in the United States. Birth control pills have been associated with a increased bone mineral density. So the incidence of osteoporosis is reduced, and there's higher bone mineral density that is thought to reduce fractures by up to 20%. You can see here that in patients who are using birth control pills, particularly throughout the life cycle, that their incidence of risk of bone mineral, fracture, is reduced as they get older, the longer they use and continue to use a birth control pill. So the birth control pills do have these positive effects. So women who start out with pills, they stabilize bone loss. The peak bone mass is generally in the late 20s in most women, and they then start to reduce bone rapidly. If they're on birth control pills during that time, that reduction is noted to be diminished. As far as lipid profile, estrogen increases serum HDL cholesterol levels and acts as an antioxidant to decrease plaque formation. And the newer birth control pills have even been noted, the lower dose pills have even been noted to increase HDL as well. So you get this effect throughout. One of the most common reasons that birth control pills are prescribed is due to acne. The combination birth control pills have been noted to reduce the incidence of mild and moderate acne. One of my favorite stories to tell is that there's a woman in Cincinnati by the name of Ann Lucky. She's a pediatrician, a pediatric endocrinologist, and a dermatologist. And back in the late or early 90s, she went from pharmaceutical company to pharmaceutical company asking if she could use their pills versus placebo to do a study on acne in teenagers. And all those the company said, no, there's no real market for us in acne. So the only company that eventually said yes was orthotricycline. It was just about to come out. They thought, well, what the heck? It probably can't do any worse than placebo. And indeed, it showed that she showed in her data that was published that indeed the incidence of acne was significantly reduced versus placebo in patients who used the orthotricycline. So because of that, from the mid-90s to the early 90s, you couldn't keep orthotricycline on the shelf. It came out and it was a big hit, and it was prescribed very widely because they were the first ones to get a acne indication in the United States. Since then, 2 other pills have gotten an acne indication. That's been Yaz, the drospirenone pill with the ethinyl estradiol dose of 20 micrograms, and also the Estrastep, which isn't used as much in the United States. Just as an aside, Yasmin initially tried to get an acne indication, as well as a indication for PMS and PMDD. My colleague who spoke previous to me talked about how hormones affect how hormones in the menstrual cycle affect mood, which is very true. We have definitely done a number of studies looking at how that occurs. I've even had patients who became homicidal and suicidal during the second half of the menstrual cycle when they had exposure to even their own endogenous progesterone that they're making. But in Yasmin, there was this initial push to get a indication for PMDD, but they didn't get it initially just because of the fact that there was some pushback by the FDA. We had psychiatrists involved at the University of Cincinnati, and we had a number of patients who had these issues, and they got better, but they didn't get the initial approval for that. But as far as acne is concerned, the way birth control pills reduce acne is the same way birth control pills also reduce hair growth in patients with PCO. What birth control pills do is by taking the pill and by sort of decreasing the production of LH and FSH in the pituitary, the LH stimulates the theca cells in the ovary, and the theca cells make androgen. So by reducing the theca cells, you reduce your endogenous androgen production in the ovary. Also, the birth control pills, the estrogen component of the combination pill, increases sex hormone binding globulin. So by increasing sex hormone binding globulin, you increase the protein that's binding, the binding protein that's binding the androgen. So by reducing androgens and binding more androgen, you reduce acne and reduce hirsutism. You also reduce the birth control pill has a slight effect in reducing DHEA and DHEAS in the circulating volume. There is a difference, though, also with the type of progestin that you use. There is a gonane. The progestins are divided into the gonanes and estranes. The gonanes are probably more androgenic than the estranes. So by potentially using an estrane or a third-generation progestin or the fourth-generation progestin, drospirenone, that will also help to reduce the amount of hormone, particularly the progestin of androgens in the system. So my second question is, does the type of progestin used have an effect on acne or midline hair growth? And of course the answer is yes, because depending on what you would think, depending on the type of progestin that's used, you could potentially have an effect on hair growth. But in all the studies that have been done, there have been no definitive answers as to which progestin is better than the other. But it's thought it's probably best not to use a levonorgestrel or a norgestrel product, which are the more potent gonanes, or the more potent androgenic components. Because remember, all of these progestins, for the most part, are androgens. So all the 19-nortestosterone agents are androgens in the birth control pills, except for drospirenone, which is a 17-carbon compound, and it has no androgenic effect. So birth control pills have demonstrated an improvement in acne. The triphasic norgestimate, or the orthotricycline, has reduced total acne lesions by 44%. Those were from the studies initially by Dr. Lucky and then by others. But levonorgestrel and norethindrone also demonstrate a reduction in acne as well. But the non-levonorgestrel products probably have even a more significant reduction in acne. So this is a slide by Sharon Plow, and they have shown that drospirenone, which is the 17-carbon compound, reduces acne just as much as cyproterone acetate, which is in the product Diane, which is not used in the United States. But you do get this significant reduction in the Yasmin type products that you don't see with a lot number of the other products. But the tricycline does just as well over time. Tricyclic pills containing norgestimate seem to be more effective than the benzoyl peroxide and antibiotics that have been used by dermatologists in the past. And in PCO patients, you get a reduction in hirsutism, and you get a reduction in the irregular cycles when you use birth control pills, and you get a reduction in endometrial hyperplasia. So in the PCO patient, the birth control pills have even more significant effect. Not only do you get the reduction in irregular bleeding and the reduction in the potential of development of endometrial cancer, but you also get a reduction in the hirsutism or the midline hair growth as well as the acne. And the way that works is by reducing the hormones, you reduce the conversion of the androgens to dihydrotestosterone. And if you use also a product like spironolactone, which you also see that effect in the drospirenone product, you also get this effect to bind to the androgen receptor without stimulating the androgen receptor. And as we sort of discussed before, birth control pills may also have an effect on menstrual cycle symptoms such as irritability and mood changes. There is some conflicting reports in the literature, but some pills may actually reduce some of the symptoms associated with the chances that patients will have some of the PMS symptoms. We see that more with the drospirenone than with any of the other birth control pills on the market. Drospirenone is a little different. Even though we studied it in the past, I think it's a good pill. It doesn't necessarily work for everyone because it has this anti-mineralocorticoid effect. There is a reduction in water retention, so some of the patients who use it may actually lose weight initially on the pill, but then that weight loss tends to go away after a year or two. Also, with the drospirenone, there's an improvement in the mood affect. As we said, we were looking at it as a treatment for PMS and PMDD. Even though we couldn't, even though the patients did well, it was never really the Yasmin initially wasn't approved for that effect, but there was a reduction in negative affect. There was a reduction in appetite and with the drospirenone, as we said, that and a reduction in water retention helped to decrease weight and an improvement in the acne. As far as birth control pills and dysfunctional uterine bleeding, even though there's going to be a talk a little bit later on abnormal uterine bleeding, birth control pills do work for patients who have initial heavy bleeding episodes. Either a tapered dose by using 4 tablets a day for 4 days and then reducing it down over time, that works. Or patients who just use pills in general up to 4 times a day continuously will notice a reduction in bleeding by 81 to 87% versus just placebo. So using a pill at a high dose and then reducing it over time seems to help very well. Patients who were given Depo-Provera noted a 70% reduction in amenorrhea over time, but there appeared to be no benefits for acute episodes. If they had prolonged bleeding on a regular basis, heavy bleeding, that Depo-Provera seemed to work but they didn't necessarily work for acute episodes. I'm a big believer, and I know that I'm sure the LARC talk will go through a lot of the continued use and why LARCs are very important, but I'm a big fan of the levonorgestrel containing products, particularly the levonorgestrel IUD. We were one of the first ones to study it, not only the Mirena, but also the Skyla, and then now the new Liletta, which I think will probably end up, once they get a 7-year approval, which they're shooting for. Right now we have patients in our studies who have been using it up to 6 years. But once the 7-year approval takes place, I think that Mirena will probably not be on the market as much anymore. But these, after the IUD scares from the 60s and 70s, the initial introduction of the Paragard and now the primary use of the levonorgestrel IUD is, I think, sort of going to be one of the standard things that patients will use in general who don't want to get pregnant anytime soon. These products are very unique. They have this reservoir of progestin, of course, in the mid portion of the IUD along the long portion of the T, and it secretes this levonorgestrel at 20 micrograms a day. The Skyla is about 12 micrograms a day, and it's obviously a smaller device. But you do get a little bit more irregular bleeding because of the decrease in the reduction of the progestin in the Skyla. When we were studying Skyla, we also looked at a 12 microgram as well as a 16 microgram IUD, and I think the 16 microgram of Skyla 2, or whatever it's going to be called, will probably come out at some point, and they're going to try to push for 5 years. But the 20 microgram IUD, which is in both the Mirena and the Liletta, it seems to be the standard dose. You get a reduction in bleeding, of course, and you get very good compliance and long-term use. The IUD works because it thickens cervical mucus, even though it does work like the copper IUD as a barrier method, because you have this device inside and you affect the inside cavity of the uterus. The contraceptive mode of action is primarily by the fact that it thickens the cervical mucus, so it doesn't allow sperm to get inside the cervix. So for those patients who always are concerned about the IUD being used as an abortifacient, the progestin IUD really doesn't do that, and neither does the copper IUD. But it does secrete this hormone. It does affect not only the mucus, but it does affect the endometrial lining, and it has an effect, obviously, on sperm to incapacitate sperm and sperm function. And as we said, it has this weak foreign body reaction. In some patients, particularly during the first year, it reduces ovulatory response. But if you continue to monitor these patients over time after the first year or so, they will continue to ovulate, but they just won't get pregnant because the sperm can't get inside the uterus. But from a non-contraceptive standpoint, and as a reproductive endocrinologist, I primarily use these for patients who have either bleeding issues. We use this sometimes in our patients who are donors, and we can actually stimulate them despite the fact that they have a progestin IUD and get a good ovarian response in these patients, and for the patients who don't want to get pregnant after their donor cycle. And you could see in this graph that before treatment and then after treatment, after 3 months, 6 months, and 12 months, that patients who have heavy menstrual bleeding episodes will get a reduction in their bleeding episode, and then obviously this will last for a period of time. In those patients who use the IUD, the levonorgestrel IUD, you can see that compared to placebo for their menstrual heavy bleeding, or compared to even prostaglandin synthase inhibitors, or compared to combination OCs, that patients who use the levonorgestrel IUD have a more pronounced reduction in the percent of menstrual bleeding, heavy menstrual bleeding, or blood loss that they have. And compared even to, this is the old day when we used to do endometrial resection versus a lot of the other things we do by placing these devices inside the uterus, that compared to resection of the endometrium, that the levonorgestrel IUD does just as good a job as any of the devices that are used to decrease heavy bleeding issues, whether it's associated with adenomyosis or it's associated with other issues. The only caveat is that in these patients who you would use and consider using a IUD for heavy menstrual bleeding, you have to make sure that there are no issues with the cavity of the uterus, meaning that the cavity isn't distorted in any way and that there are no polyps or fibroids in the cavity that wouldn't allow the IUD to work as well. So there does appear to be an alternative to hysterectomy in a number of patients, and I think overall you've seen a reduction in hysterectomy because there are other alternatives, whether it's an IUD or any of these other devices that are used to burn or freeze the cavity of the uterus, or even medical therapy. So hysterectomies aren't being done, to be honest with you. Our residents don't get the number of hysterectomies that they used to, which is great for patients. Not everyone needs a hysterectomy. But we do have these alternatives so that patients don't have to undergo a hysterectomy needlessly, because believe me, there are a number of patients that I see on a regular basis who come back and say they wish they hadn't had their tubes tied, wish they hadn't had a hysterectomy because they meet someone and they want to get pregnant. The most common thing these days is for ladies who are in their 40s who meet a person online who's in their 30s, and the guy doesn't know that they're in their 40s, and they want to get pregnant to not only have a child for that person, but I think getting pregnant is the new cool thing now these days. I had a lady who was 55 the other day who came in because she wanted to get pregnant. Her new husband was 29, and they... That's right. We don't judge, but our cutoff is 50. So one lady who was 60 told us that she was 45, and she looked great, but we did ask for a driver's license. And we told her we couldn't help her. But it is not uncommon for those types of things to happen these days. As far as dysmenorrhea is concerned, oral contraceptives reduce dysmenorrhea by reducing prostaglandin content in the menstrual fluid. In a normal menstrual cycle, you get an increase in prostaglandins in the uterus, in the endometrial cavity, and in the menstrual fluid that's noted at mid-cycle. Birth control pills actually reduce this by reducing the hormonal escalate or hormonal changes in the body, and by reduction in local endometrial vasoconstriction and ischemia, also causing a decrease in the blood flow, which causes dysmenorrhea. And this seems to also, if patients take this on a continuous basis, obviously, and reduce the amount of bleeding that they have overall, that also obviously reduce their dysmenorrheic episodes. Also, patients who do take continuous birth control pills and have bleeding, if they stop it for 3 or 4 days, then restart it, that tends to also reduce some of the dysmenorrhea they may have with breakthrough bleeding issues. No progestin seems to be superior in this, even though I tend to use a levonorgestrel type pill in these patients. But a number of studies have been shown that no necessarily one progestin versus another doesn't appear to reduce the dysmenorrhea or pain issues that they see. And continuous use also reduces the risk of menstrual migraines that patients can potentially have. So my next question is, what's the ideal contraceptive in a perimenopausal woman? Is there an ideal contraceptive in a perimenopausal woman? Actually, to be honest with you, there doesn't appear to be one that's necessarily better than the other. The perimenopause, the biggest issue is to try to not use it in non-smokers. Obviously, in smokers over the age of 35, they shouldn't necessarily be using the combination pill, but keep in mind that that data is old data from pills that are probably 50 micrograms or more. So we don't probably really know how much of an effect smoking has, even though it's still thought that patients should reduce their cigarette use by at least less than 12 or 15 cigarettes per day. But whether or not these 10 microgram pills have an effect, any adverse effect on in smokers is not really known yet. It does reduce, as we said earlier, the combination pills reduce bone loss, so even a small amount of estrogen will help. When we look at equivalent doses, we know that in a menopausal woman, for those of you who still prescribe menopausal hormones, 0.625 of Premarin is noted to be helpful in having a significant diminution in bone loss. 0.625 of Premarin is equivalent to 5 to 7 micrograms of ethinyl estradiol. So any of the birth control pills that are on the market today should be helpful in doing that. And if you kind of keep these equivalents in mind, we're using a lot of the birth control pills as we go down to 10 micrograms are getting to the dose of what we see in a lot of the hormones that we use in our perimenopausal and in particular our menopausal women. But the combination pills increases calcium absorption, reduces or decreases calcium loss, and inhibits osteoblastic function. Therefore, and also we get a reduction in the risk of endometrial hyperplasia. So as perimenopausal women go through these episodes of anovulation, which puts them at higher risk of endometrial hyperplasia and therefore cancer, just like you see almost in the beginning of the menstrual cycle when women go through the menarche and they start to have these anovulatory cycles and have these heavy bleeds. If the perimenopausal women they go through the same thing. They go through these anovulatory cycles and they start to develop hyperplasia. But low-dose pills not only reduce a lot of these effects, it also has an effect, to be honest with you, in reducing some of the mood changes that we see. The levonorgestrel IUD reduces the risk of endometrial hyperplasia in these patients, reduces the risk of bleeding, decreases the risk of some of the progestin-related side effects that you would have if you take the pills orally. So it reduces the mood changes that you can sometimes see in the birth control pills in these patients who may be very sensitive. Not only do you do that, you can also reduce, as we said, some of the bleeding issues, and it also reduces polyp formation. So as a patient gets older and you see these increase in polyps, and we see a lot of them in our fertility patients because we're looking for them by doing a lot of cavity evaluation before they go through a cycle. The use of an IUD in those patients who aren't trying to get pregnant will help, is noted to reduce with the levonorgestrel IUD. And you can use it in patients who are on or who want to use an estrogen therapy. As far as the levonorgestrel IUD and hormone replacement, the advantage of if a patient has an IUD in, there's no reason to take it out. They can take a estrogen and the levonorgestrel IUD, which can be used up to 5 years, the current Mirena and the Liletta. It not only helps reduce endometrial hyperplasia from the estrogen therapy, just by having that local effect, you have an effect such that you don't have to take a oral progestin, which can cause some of the depressed mood issues that we talked about earlier. And so a lot of these patients who don't like to take the hormone therapy because if they have a uterus, they have to take a progestin to protect their uterus. They don't have to worry about that with the IUD in place. Also, in patients who continue to use the levonorgestrel IUD or IUS when they are on hormones, bleeding is one of the reasons that these patients may actually stop their hormone use by using the progestin IUD. They don't have a lot of those bleeding issues because the majority of them, 83 to 88% will have no bleeding at 12 months, and that amenorrheic effect from the IUD will continue beyond that 12-month time frame. So in my group, where we're trying to develop a new contraceptive agent, we're always trying to find one that pretty much has these sort of criteria. So then when we sit down and try to map out what makes a good contraceptive agent, we're trying to find one that's, of course, safe, effective, obviously is very important, reversible. So for those patients, despite the fact that they don't want to ever get pregnant again, from my standpoint, a lot of them who said that want to get pregnant. The number of patients who've had Essures placed, the little device that goes inside the uterus, who then want to get it out 2 months later, those numbers are very high. So something that's reversible, something that's acceptable, available so they can get it very easily, either over the counter or from their physician or practitioner, affordable, and that has non-contraceptive benefits. So those are the things that we look for in developing a contraceptive agent. I've been involved with the Contraceptive Clinical Trials Network with the NIH since 1995. It was the first NIH grant I ever wrote, and I was 100% at that time. Unfortunately, I can't say I'm 100% now, but I'm doing pretty well. There were originally 9 centers involved. We now have 19 centers, and there are also now 5 male centers. I didn't talk about male contraceptive here, but that's one of my other favorite talks to talk about, is the development of male contraception and where we stand with that arena, which isn't very far, to be honest with you, other than condoms and new condoms and condoms that vibrate and glow and things like that. That's basically male contraception in the United States. But we have done a number of different projects. One is a ulipristal project, which ulipristal, or is now used over the counter as Ella, which is a pulse-coital or emergency contraceptive agent. We've also developed through the contraceptive network buffer gel, acidiform gel, which are spermicides that just change the pH of the vagina, and by changing the pH slightly, by reducing the pH or making it more acidic, that helps to reduce and activate sperm. We've even used an easy-on condom, where it can be used either way, so that men can place it without the condom flying across the room. So making it as easy and painless as possible. The big thing now in our contraceptive group, to be honest with you, I didn't put on here, are copper IUDs. Copper IUDs are going to make a comeback. We are starting to develop newer and different types of copper IUDs. There's the ball and the different types of copper IUDs that we're looking at. Depo-levonorgestrel, so using a levonorgestrel instead of a Depo-Provera is something that we are working on with the group in the Primate Center in Oregon. We hope to start to using that in humans. There's some things that we need to work out with how long it lasts. We're trying to come up with either a 4-month or 6-month variation of a injectable or a self-administered once-a-month injection that a patient can kind of take on their own, a sub-Q. This is the new thing we talked about in the last couple of months, is to come up with a sub-Q once-a-month injectable version so that patients can just take it on their own at home. The other thing that we're trying to work out with the Buffett Foundation is these multi-purpose therapeutic modalities, like a multi-purpose ring, meaning that you have a ring that contains a progestin as well as a antiviral agent. So using a combination ring, the Buffett Foundation has used a lot of these in Africa, and they're starting to use them initially in primates, and then now they're thinking about using them in Africa first. But that's one of the things we want to introduce in the United States, which would be a ring. These rings, believe it or not, if you talk to a lot of these contraceptive developers, these rings can contain up to 9 different hormonal, they have 9 different channels. So you can use these rings for a number of different things. So not only as a contraceptive, but also as a antiviral agent to reduce the risk of HIV, so tenofovir, and a number of the antiretroviral agents. And I know that in the studies that have looked at in primates, they've used it, and they've had a ring that had a progestin only, and then a ring that had a progestin and an antiretrovirus. They introduced the HIV virus, and there was a reduction in the progestin only by only 10%, but in the one that had a progestin and a antiretrovirus, there was no pickup of HIV by those animals. So these devices, and hopefully not only being able to use them for a reduction in HIV, but also gonorrhea, chlamydia, HPV, those types of things are on the table. Some of the things that we've done in the past, ulipristal acetate, which was initially known as CDB 2914, we compared that to a divided dose of which would be Plan B, and the levonorgestrel pill for as an emergency contraceptive agent. And we noted Ella or CDB 2914 or ulipristal had an 85% chance of reducing pregnancies if used as a postcoital contraceptive agent versus the levonorgestrel, which had a 69% rate of preventing a ongoing pregnancy. With the buffer gel, the gel that we talked about that reduces the pH versus minoxidil 9, which is a surfactant, it just actively kills sperm when used with a diaphragm, when diaphragms were available. The buffer gel actually tended to do just as well by reducing just the pH. The buffer gel did just as well as the minoxidil 9. So you can see in all users, in patients who used it, there was a reduction of the failure rate was 10% versus 12%. But in patients who used it consistently, because all these patients weren't perfect users, so in the perfect users, the people who used it consistently, the reduction in pregnancies was 4.7% with the buffer gel and 6.1% with the minoxidil 9. So the goal in any of these contraceptive trials and a lot of things that we're doing is to continue to bring as many products on the market as possible as we move toward potentially getting levonorgestrel over the counter as a contraceptive agent. And overall, we're starting to see a reduction. I'm sure we'll talk about that at some point in the LARC talk. But there is a reduction in pregnancies overall. A lot of that is thought to be due to a lot of these products that are coming out on the market, and we hope to have many more over the next 10 to 15 years. Thank you very much.